Hi, welcome to the Doctor's Debrief podcast, presented by NDMD Productions and hosted by me, Vivian McCool, first-year medical student. Here on Doctor's Debrief, we're going to take a dive into some of the most impactful patient cases of a physician's career, the ones that are forever imprinted in their memories and have played a crucial role in shaping their identity as a physician. Although all of us have experience with facing and overcoming adversity, we seldom talk about the skills we use or the lessons we learn along the way. That's why, here on Doctor's Debrief, I'm passionate about being transparent about these hardships and the methods we use to overcome them to encourage others to follow their dreams and learn from every step of their journey, regardless of their circumstances. I'm your host, Vivian McCool, first-year medical student. You can find my YouTube channel in the link in the description below. And with that, please help me welcome today's guest. Today's guest is an infectious disease physician who is widely recognized as an expert in HIV antiretroviral therapy, resistance to antiretroviral drugs, and sepsis. He received his master's in general psychology at Columbia University before receiving his medical degree from the University of Illinois. His clinical interests include HIV, sepsis, hepatitis, deep soft tissue infections, and global health. He's widely published with over 90 manuscripts in peer-reviewed journals, and his current research interests include antiretroviral resistance, adherence to antiretroviral therapy, especially in underrepresented populations, influenza, and Clostridium difficile colitis. He's also an ad hoc reviewer for the NIH and the Ontario HIV Trials Network, and he's the local COVID-19 expert for the Augusta and surrounding communities, being featured on local news networks for his expert opinion many times throughout the pandemic. Honestly, this man has done it all and serves as an amazing mentor for medical students by being a preceptor for us and offering lectures on his areas of expertise. So welcome, the one and the only, Dr.Rodger MacArthur. Dr. MacArthur, thank you so much for being here today. I'm so excited for our interview.
Thanks, Vivian. It's a pleasure to be here.
So Dr. MacArthur was my first preceptor for medical school, and I feel so lucky for how those cards were drawn. His years of clinical experience benefited my education as he was able to paint a picture for me that you can't get unless you've lived it, and it definitely impacted the way I perceive cases going forward. His care for his patients and his passion for advocacy reaches all of his students, and he's just the most amazing example of what being a physician is all about. But before we get into it, is there anything that I missed or might be of interest to the bright students listening or watching right now?
I think you covered it pretty much. I've been doing this for a long time.
Doing it well. So, Dr. MacArthur, what brought you to medicine in the first place, and why infectious disease?
So I didn't go directly from undergraduate to medical school. I had done a lot of research, actually starting in high school, and continued that in college. And so I thought that would be my path, my career path, getting a PhD, which is the main reason I went to Columbia University in experimental psychology. And I got a master's there, and it was a good experience, especially being in New York City back then. This was in I guess you'd have to say it was in the late 1970s. Fun time, but it wasn't as satisfying as I thought. Along the way, of course, I think we all considered other options. Many of my classmates considered business school back then, law school, and I certainly considered medical school. My mom was a nurse, and she brought it up, but I thought research was where I needed to be. So I went the research route, and it just wasn't as satisfying as I thought. And so I started to think about other options, and that's what led me into medicine.
That's cool. I didn't know that.
Well, yes. I applied to a number of medical schools, took all those exams. I had been as an undergraduate at Northwestern University. I was a double major in psychology and biology, so I had all the prerequisites for medical school. And it was just a matter of taking the MCAT exam, which was different back then. Back then, I think it was on version 3 that I took. I don't know what version they've got now. But it's the same basic idea. You have a physics section, you've got a chemistry section, a biology section, and who knows what other sections they had. And there was the studying for it that everybody has gone through. And I did not bad on it and got into a number of schools and chose University of Illinois, in part because of the state tuition that I could get. I was an Illinois resident at the time. And I was very interested early on in microbiology. And that's sort of what led me into infectious diseases. But then for my internal medicine clerkship, my first clinical, during my clinical year, my third year then, I just by luck of the draw, was assigned to a world-renowned infectious diseases physician who was just brilliant. I mean, it was just amazing just to sit there at the same table with him and just watch him work through a case, work through a problem, work through something other than infectious diseases. And that sort of sold me on it. I did some research with him, and while I've enjoyed a lot of things in medicine and was sort of uncommitted when I went into residency except to go into internal medicine, there was nothing that I enjoyed more than infectious diseases, and so I went that route.
Well, you're definitely I think you are now like that guy for like the rest of us. So like, what did your mom practice with nursing? What did she do?
A general nurse.
Okay.
She actually, at the end of her career, did home nursing as well.
Okay.
And I'm sure she had different ideas of what doctors were, what they were supposed to be. Sort of, it's an old television series, Marcus Welby, where it was the family doctor. And, ironically, we need a lot of really good general medicine doctors, especially in rural Georgia and elsewhere. They can really make a difference. Yeah. And I think that's the vision she had for me, but that wasn't the direction I went.
Yeah. Well, you've done amazing things, and you're giving back in like such an impactful way. Like, you impact us all so much. So do you ever like have regrets? Do you ever wish you did something else, or are you happy with this specialty?
I'm very happy with infectious diseases. There are a lot of things that I liked along the way, including pediatrics, including surgery. But in terms of internal medicine, I'm very happy with infectious diseases. It's a great subspecialty. The word is that we get to see the best cases, and we do.
Truly.
And we can really make a difference. One doesn't need to be infectious diseases trained to prescribe antibiotics, but that's only one part of what we do. We have to understand what it is that we're treating. We have to make the diagnosis. We really work through the history, and we pick up on things that maybe others miss, in part because we just take the time to ask the really probing questions. And it might seem at times intrusive, unnecessary, but it's amazing how important it can be in making the diagnosis.
Yeah, I think with infectious disease especially, because like things can be so tricky and manifest in similar but different ways. And also just being an advocate and being like a sounding board, someone like your patient has to be comfortable with you, or else you're going to miss clues. And I think you do a really good job of like being open and welcoming and like non-judgmental, where a patient will be open to talking to you about things, so you can get all the info you need. Yeah. So people visit you as an infectious disease doctor in the most like dire, vulnerable moments in their lives.
Well, they often do, and so in the hospital I see patients with all sorts of infections. They've come out of surgery and they've got a wound infection, or they've got pneumonia, or they've come from an extended care facility with, perhaps it's a bladder infection. In the clinic, I focus still on HIV, but in that capacity, those of us who see HIV-infected patients, we take care of other aspects of the patients. First-line therapy for hypertension, for instance, maybe even second line. We are concerned about diabetes. All these are risk factors for bad outcome, and it's not just HIV that we focus on. We need to incorporate our general internal medicine background as well, which is really a lot of fun. Medicine itself is a great field, and there's so much to it. And I think it's unfortunate when a subspecialist gets too wrapped up in their own subspecialty and loses sight of all the other aspects of medicine that they learned along the way. I mean, I can't do rheumatology like a rheumatologist, but I need to know a bit, some more than a bit, about rheumatology or oncology or nephrology or things like that.
Yeah. And that's so you can treat the whole patient.
Absolutely.
Yeah.
Absolutely.
Not just like whatever they're coming to you for or what you think they were coming to you for. And I think with infectious disease, you have to get creative sometimes, because I know sometimes you might like aspirate a wound and like you don't get the bacteria you're looking for, or you don't get anything, and you have to like try again. And it just takes someone who is willing to, like, who's not going to give up.
Right. And who looks for, as you mentioned, clues, or tries to make the diagnosis rather than just throwing one antibiotic after another at something that may or may not be infectious.
Yeah.
We get a lot of consults for patients with a fever. What's the cause of the fever? There are, as you know, there are a lot of non-infectious causes of fever, and we have to be able to figure that one out. Mm-hmm. Many assume that fever means infection. Well, it doesn't always. We work through those things.
Yeah. Yeah. So you've seen a lot of things, and you've helped a lot of people in some of their most vulnerable times. If you had to pick one of the most impactful cases of your career, what do you think would be, like, what's the first thing to come to mind?
Well, I've got three.
Okay, let's hear them. I'm really excited.
It's a bit much, I know.
No, I want to hear them.
But there are three. So a couple go back decades, but one was more recent. So I'll start with one of the older ones. It was let's call him a early 30s, late 20s young man who was transferred into our hospital for what was diagnosed, or what they called a fever of unknown origin. And it turns out that he had pneumocystis, which is a condition that especially HIV-infected individuals get. Mm-hmm. That's what he had. Now, this goes back to 1995, a long time ago. HIV care was very different. Mm-hmm. We didn't have the really good drugs back then. I made the diagnosis of pneumocystis, and of course we confirmed that he was HIV infected. He was married. He had one relatively young child, and he got better. But his question to me was, would he live long enough to see his daughter graduate from high school? Very sad.
Yeah.
But for him, that was the most important thing, to see her graduate from high school. And this was, he was asking really, would he live for 3 to 5 years? I told him I thought so. And he did. Then he asked, well, would he live to see his daughter graduate from college? I said, by then we had some better drugs. Yes, I think you will. Uh-huh. And she did. Then he asked, well, she's now out in the world. She's got a job. You think maybe I'll be alive long enough to see her get married? And I did. And he ended up working a full career. He retired. He invited me to his retirement party, which was very nice. I went.
That's awesome.
It was, very nice. I got to meet some of his coworkers. And for the first time, I met his daughter, who... I don't know when she found out that her dad had HIV. He ultimately told her, not early on, but he ultimately told her. Mm-hmm. And it was very touching. She thanked me for saving his life.
That's really touching.
It was. And he's done well. And again, it starts with the diagnosis, but really all of us in the field got lucky because we had these great drugs that we, over time, learned how to use. Mm-hmm. And... also, he did a great job of taking the medication. His wife made sure he took the medication. And it all worked out well.
That's awesome.
So I unfortunately, I haven't kept in touch with him, so I don't know how he's doing now.
Yeah.
But now go forward another, say, 6-10 years. And yes, we had the better drugs, but not everybody that was using them knew how to treat them. So I took over the care of a woman who's, quite honestly, her physician messed things up. And that's itself very difficult. She was very attached to her physician. She's actually from Georgia and has actually lectured our students. So I'm telling you sort of the ending. She's still alive. But she was dying. She was dying and didn't really know it. She was dying slowly because of complications of HIV that really was just ravaging her immune system. And if you looked at her virus, as I did, it was resistant to pretty much everything we had. Ooh. And it was all because her physician would prescribe the wrong drug, one drug at a time, in the wrong doses. And she was pretty angry about everything. She had herself 2 or 3 young kids, and at some level understood she was not doing well, and didn't trust the medical establishment, didn't trust other doctors, was still grieving that her physician that she did trust had left. And so I showed up, and she didn't know whether to trust me, but she did ultimately. And she, at the time I saw her, she truly had essentially no immune system left. Oof. Now she's got a great immune system. She started her own business, saw kids graduate, and she's lectured our students, as I said. She continues to do well, and this is now, probably 20 years later or so, 15, 20 years.
Wow.
And she said, she keeps in touch, sends me Christmas greetings every year, sends me New Year's greetings, and she says she's coming to Georgia, wants to see me and all the students again.
That's awesome.
And really told our students that she has tremendous respect for the Medical College of Georgia and their students, and was really quite willing. This was not for your class, but a class or so ahead of yours. She let them choose her next round of antiretroviral therapy.
Oh, wow.
Based on what they knew about her.
Oh, too much trust in us.
A lot of trust. And I wrote a blog piece about her. And she's very open about using her name. I won't use her name, but the blog piece has been published, and it was titled Rage. She was, as I said at the time, somewhat angry. Yeah. But she's a wonderful person.
That's awesome.
Then, more recently, here at MCG, we were consulted on a young woman in her 30s, with a fever that had started, 6 weeks earlier. They didn't know what was going on at another hospital center here. She'd been seen by others. They ordered lots of tests. Nothing too remarkable showed up. But nobody had taken a thorough history. Nobody had taken a sexual history. I did, but there was nothing there. Nobody had done really what they needed to do, although they talked to her. And she had some minimal elevation of her liver enzymes, and so she was being scheduled apparently a few days later for a biopsy of her liver, a closed biopsy of her liver. I had to find out what was going on. But the key question to ask, which I did, was, her husband was always in the room. She was married. Besides travel history and things like that, was, do you have any pets? Well, she had a dog. Dog was, just dog that she kept in the house. And she enjoyed looking at birds, but they were just cardinals that would come, and she'd feed the cardinals. But I pursued it further and asked her if she had any contact with unusual animals. Mm-hmm. And she said, well, as a matter of fact, a couple of months ago, she and some girlfriends went to Greenville and visited a bed and breakfast. And the feature there was that they had baby goats. Baby goats. And Baby goats. Ah. That was the clue.
Wow.
Baby goats. And her husband was getting pretty upset. He thought this was just the most bizarre question he'd ever heard. I mean, everybody's asking her about lots of things along the way, and I come in, I ask her about goats.
And animals. Yeah, he's like, what does this have to do with her health?
And who is this person who's asking about goats? Well, it turns out she was one of about 100 people in the U.S. That year that got brucellosis, which is a serious bacterial infection acquired, in this case, from goats. And they were newborn goats. She let the goats lick her face. Mama goat gave birth to 3. One was stillborn. And I asked her, why did she let the goats lick her face? She said, well, they were so cute.
She's cute. Like, why not?
Why not? But she was thrilled with the diagnosis. Her husband went home that night and did all of his research on brucellosis and was very proud of knowing more about brucellosis than some of our medical students. He was able to tell the species and so forth.
Oh, wow.
But she was greatly relieved. And no doubt, and she told us later, she was convinced she was dying of cancer, that we just couldn't figure out what kind. But it was a treatable disease.
Yeah.
And she said, use her name. Some of our fellows have written her up and presented her at conferences.
Wow.
But it sticks with me because it's a matter of making the diagnosis.
Yeah.
And it's really just by chance. I was on service that week. We got consulted. I went to see her. And
she got lucky.
And she did to a large extent. Brucellosis is a difficult diagnosis to make.
Yeah.
And untreated, it leads to all sorts of progressive joint issues. It's called undulant fever sometimes because the fevers come and go. It's a very memorable case, and I've mentioned it to others. We might even turn it into some kind of simulation.
I thought you were about to say CBL case. I was like, that's going to stump them.
It might be a CBL case, or Dr. Giroux had mentioned she might want to do it as a simulation to emphasize the importance of taking a history. So those are 3 that I wanted to leave you with, and they will stay with me always. The 2 HIV and the 1 general ID.
That one is so, like, when I think infectious disease, I literally picture like a private investigator like trying to solve the crime. And like that case truly encompasses that. Like, you were asking about animals, and that's how you got down to it.
Yes, absolutely. And then I mean I was taken aback by her husband saying, "What is going on here? You're asking about goats? You're a doctor and you're asking about goats?" But that's that. And we teach this. We teach the associations.
Yeah.
And sometimes it doesn't always follow, but there are known animal vectors of some of these bacterial infections, and knowing that, and knowing that it can cause a non-specific inflammatory infectious disease process, fever that comes and goes, other non-specific findings, with nothing else so obvious that had been ruled out, it needs to come to mind.
No, you are so talented at this. Like you wanted to do research, but like your talent for like investigating and research and like your care for people just makes you like so solid. Like you were made to do this, I think.
Well, I thank you. I enjoy doing it, and I enjoy making a difference. And I tell students that they too will make a difference, and it's a great feeling when you can. I mean, for whatever reason, or whatever the reason was that students today go into medicine, almost all of them will, if not all of them, will make a difference in at least one person's life, and that's an amazing thing.
Yeah, no, that's the goal, to change at least one life. So, Dr. MacArthur, from these cases, how do you think they shaped you as a physician going forward?
Well, it reinforced my decision to go into medicine. It keeps me interested in staying active within the field and not taking early retirement or something like that. I get to do a lot of fun things. I enjoy seeing the patients. I enjoy doing research. And I especially enjoy teaching, and I like to be able to relay these cases to students in a teaching format and hope that maybe it resonates in some way.
Yeah, no, it definitely does. You've impacted my education so much in just the few months that you were teaching me. So how do you think they shaped you as a person?
I think I've become a lot more accepting. And I say that specifically to HIV. When I started in HIV, the first patient I saw die of AIDS was back in the mid-1980s, 1985. I did fellowship training from basically 1986 through 88. And we had no drugs to treat HIV. And I didn't have any plans at that time to go into HIV. But a lot of my colleagues who were in training at that time, a lot of those who had trained before me, had absolutely no interest in HIV, in part because they didn't approve of the lifestyle of individuals who were getting HIV, whether at the time it was injection drug use or men who had sex with men. They just couldn't get beyond that and basically treat a condition that was ultimately treatable. So I left. I did training, fellowship training in Baltimore. Left Baltimore for my first academic job in Toledo, Ohio. And I got there, and they said, just to let you know, we don't have any HIV in Toledo, which, of course, was a stupid comment to me. And I said, well, why is that? Well, we don't. We just don't have it here. You have it in Baltimore. Maybe in Detroit they've got it, but we don't have it in Toledo. I said, but if we're wrong, you're going to do it all. you're going to see them. So, all right, fine. So that's when I realized, that's when I learned that I actually enjoyed the interactions, that the individuals I got to treat were not just cases, not just another individual with HIV, not just somebody with a virus that was becoming more resistant, but real humans with interesting stories, with families, with dreams, with caring partners, caring family members, and that really made an impact on me. I really enjoy that aspect of it, and to this day, I enjoy the aspect of it. Again, a lot of my patients take really good vacations. They go on cruises. They go off to Europe. They go to the Caribbean. And we talk about that because it's easy to treat, relatively easy to treat HIV these days. Yeah. But it's the human quality that I got to see, the human interactions, and then broadening me and becoming more accepting of lifestyle and other aspects of the care. And I think that really is a result of HIV.
No, that's beautiful. I love that because, yeah, I feel like back when, I wasn't around for it, but I know that back when, HIV was first impacting patients, there was such a stigma around it.
There was. I was walking down the hall as a fellow, and at that time, all the HIV patients were put on one floor. They were all put in the private room, and one patient opened his door to walk out in the room, and a nurse yelled at him, screamed down the hall, "Get back in your room, you've got AIDS." They didn't have HIPAA back then, and all the healthcare issue violations.
Yeah, think about that. Oh, snap, I didn't even think about that.
No, and it's just, there was fear. Everybody thought that if they were even around them, they would somehow mysteriously acquire HIV and that they would surely die. And that's not the case. But it was a different era, and that's when I trained.
Do you think you learned skills and resilience from these HIV patients?
I hope I did. I mean, they've gone through a lot. And if you talk to the long-term survivors, even if they don't use that term, those who were diagnosed with HIV in the, say late 80s, early 90s, even earlier than that, they'll all tell you that they didn't think they'd live for 4 or 5 years. And they did. And they've been through a lot. Some had symptomatic disease, some did not. Some had side effects from the medications. And absolutely they were resilient. And they did it. We didn't know how to dose some of these medications, and so we would tell them early on to dose one medication every 4 hours. It's really hard to take a pill every 4 hours, but they would do it. They'd set their wristwatches to wake up in the middle of the night. Every 4 hours they'd be taking a pill.
Every 4 hours, all day, every day?
All day, every day.
Whoa.
6 times a day, 7 days a week. And not just one pill, typically 2 or more.
Wow.
But that's what they would do.
Yeah.
And they persevered. And many of them changed their lives, mostly in a good way. But it was not easy. No doubt it led to divorce, separation in a number of cases, maybe abandonment from family members.
Yeah.
But they did teach me a lot about resilience. All of us can come down with one chronic disease or another, whether it's diabetes or something else. And what are the options? You can ignore it. You can be angry, or you can just try to deal with it. And I think having decades of experience with individuals who did deal with it and did so well has really impacted me for the better.
That's awesome. That's awesome. I hope to never get sick with something like that, but I hope if I do, I have the same type of grit and positivity, because that is rough. How did you cope with telling people they had this disease when there was no treatment or poor treatment? Because back then it was almost like a death sentence.
It was. Back then, when I saw them, they were coming into the hospital, so they were already very advanced and very sick. And so the focus was on what infection did they have or acquire as a result of having a devastated immune system. And so that was really the focus. They were going blind. We'd have to deal with that. They had untreatable cancers, lymphomas, and that was the hard part, seeing them lying in bed, blind, surrounded by their family, and there was nothing we could do. It was incredibly sad. It was, in many ways, understandable why people didn't want to go into HIV because, well, whether it's HIV or oncology, if you've got nothing to treat them with, all you can do is deliver the bad news.
Yeah.
But then, with the better drugs, and that's true also with oncology, you can give them good news. You can give them hope.
Hope is restored.
It is, and it's a very powerful thing when you can give hope. And it's been a journey seeing the changes in HIV. It's hard to imagine the differences sitting here today to what it was like back in the 1980s, in the mid-1980s. Just very different.
I literally cannot imagine.
But everything is good now, which is good.
Yeah, there you go. Thank God everything is good now. So, Dr. MacArthur, is there anything else that we can hear from you before I move on to the next set of questions?
No, I think that's good. I'm happy to have been allowed to tell these very impactful case stories and give you a little bit of my background as to why I went to medical school and my career along the way.
No, thank you for sharing. Those stories were just really impactful and truly moving, and I appreciate your honesty and willingness to share them with us. So before we do wrap it up, I wanted to ask a couple questions that might be of benefit to the future medical students watching or people in med school who are going to be applying to residency soon. What is one piece of advice that you would give to a prospective medical student watching or listening right now?
Medicine's a great field. Whether you choose pediatric surgery, radiology, whatever you choose, it's a great field. A lot of things you can do in it, whether it's impactful research or impactful clinical care. And my advice is do what makes you happy. And also don't obsess about, don't worry about reimbursement. Don't choose a field based on how the reimbursement structure is set up and how much you'll make. That's not a good reason to go into medicine, to make money. There are many reasons to go into medicine. Almost all of them are good, but a bad one is to make a lot of money.
So true.
That's just not why you need to go.
No. It just takes too long. If you want to make money, do computer science or something.
Well, I just there are so many aspects of medicine that I love. My least favorite aspect, the one that I don't love, is any mention of billing or generating revenue value units or whatever they call them, RVUs. Billing. We all have to do it. Obviously, we need to get reimbursed for what we do, but it's just, to me, distasteful to think about the money aspect. It's a business.
It sucks.
But focus on what makes you happy, and realize that you're talking about decades worth of a career, and no matter what you choose, there are going to be times when you wonder if you should have chosen something else, or you'll have a bad night. You'll be up all night long taking care of a very sick patient, and maybe you'll think about whether you should have gone to law school or something like that instead, where you can get a better night's sleep. But you're less likely to have those thoughts if you go the route that you know will make you happy.
Well said. So speaking of billing, actually, kind of like pivoting from this, you taught me about indigent funds. And I recently heard that our institution is going to be like limiting the indigent funds to only patients who like are going to die or something.
I hadn't heard that.
Okay.
So I really don't have any comments to make on it.
Okay.
There's so much need out there.
I know.
For being able to afford care.
Yeah.
Our healthcare system needs to be fixed. I think pretty much we can all agree on that one.
True.
I'm going to turn that one over to you and your classmates to fix the system.